Good evening again, all of our viewers from all over the world. Today we have the Saturday Congenital Heart Diseases at CEC course. This is the sixth webinar. We will be discussing obstructive lesions in congenital heart disease. This is the part concerned with the left-sided obstructive lesions. I have a very elegant speaker on board, my dear friend, Dr. Yasmin Abduraziq. She is a lecturer of cardiology at Ain Shams University, and she is a consultant for congenital and structural heart disease in the Ain Shams University unit. Moderating this session will be three of my friends and colleagues, Dr. Sara Muscatelli from Italy, and she's currently in England, London, Royal Brompton. So we wish her and congratulate her for this big step and wish her a big success. We have also Dr. Khalid Shams, consultant of congenital heart disease and lecturer of cardiology at Helwan University. And we have also Dr. Hatem Hosni, consultant of cardiac surgery for congenital heart disease patients and consultant at Aswan Heart Center. So after this brief introduction, I will pass the mic to my dear friend, Dr. Yasmin Abduraziq. She will start her lecture, and Sarah, Khalid, and Hatem will be moderating the session with her. So please start, Yasmin.
Okay, thank you, Dr. Zahran. It gives me all the pleasure to be with you today in your elegant channel, cardiology educational channel. We'll talk today about obstructive lesions in congenital heart disease. We will focus on left-sided obstruction. I hope that by the end of this session, we will be able to recognize normal and abnormal blood flow, know well left-sided obstructive congenital heart diseases, their different levels, their pathophysiology, and how to manage patients with different levels of left-sided obstruction. Okay. First, I will remind you about what is normal blood flow and what is abnormal blood flow. Normal blood flow is laminar without increase in velocity, with equal cross-sectional through all points of flow. Once you have obstruction, you will have increase in the velocity, as according to the continuity equation, at each point of flow, the amount of blood flowing is equal. So this quantity of blood flow equals to the cross-sectional area times to the velocity. So if you have an obstruction, you will have a decrease in cross-sectional area, and you must have an increase in the velocity. This increase in the velocity will lead to murmur that we hear, will lead to post-stenotic dilatation, higher probability of infective endocarditis, and other points that we will see in pathophysiology of different obstructive lesions. As I said, we will focus today on left-sided obstructive lesions. We have congenital mitral stenosis, left ventricular outflow obstruction, valvular aortic stenosis, supravalvular, and aortic coarctation. Those are the obstructive lesions on the left side, and the most extreme form is aortic interruption. In this slide, we will show different, and we will enumerate different levels of obstruction of left side. I will start with the most common type. It's the valvular type. It's 71% of obstructive of aortic stenosis. The most common type is bicuspid aortic valve. The second common is a thickened tricuspid valve, and the last one is the unicuspid valve, which usually present with critical aortic stenosis in a neonate. The second common type of left side obstruction is the subvalvular obstruction, which may be in the form of a focal discrete subaortic membrane or a diffuse tunnel. Following that, the supravalvular obstruction. Here we can see it is between the sinuses of Valsalva and the ascending aorta. We can say just after the sinotubular junction. It can be isolated or associated with Williams syndrome. Of course, you know, Williams syndrome is associated with mental retardation or it can be isolated just supravalvular aortic stenosis. And lastly, the coarctation of aorta. First, I will start with the pathophysiology of aortic stenosis and coarctation. But first, I will mention the Shone complex. Shone complex is multi-level obstruction in the left side. As we can see here, it can be above the mitral valve, in the form of supramitral ring, or congenital mitral stenosis, or subaortic stenosis, or valvular aortic stenosis, supravalvular till aortic coarctation, and can be associated with hypoplastic ascending aorta and arch. So patients with Shone complex have multiple levels of obstruction. Not every patient have all levels of obstruction. He can have some of them. It can also be associated with other congenital lesions. I'm mentioning Shone complex as I want everyone, when he meet one of these lesions, when he meet aortic coarctation, he must revise his patient, look at the mitral valve, revise if the patient have mitral stenosis or not, have aortic stenosis or not, as I think Shone complex is not uncommon, and we see it usually in our practice. In the coming 2 slides, I will discuss the pathophysiology, first of aortic stenosis, then of aortic coarctation. Then after, we will see a number of cases. Each case will show us a level of obstruction, its clinical manifestations, and how we diagnose it and manage it. And here in this slide, the pathophysiology of aortic stenosis, we have obstruction of the left ventricular outflow. And this causes the inability to increase cardiac output during exercise. So usually patients with aortic stenosis has dyspnea on exercise, or can have pre-syncope or syncope, usually after exercise. And in late stages of the disease, symptoms become at rest also. The other point that because of this obstruction, we have LVH, which causes relative myocardial ischemia, also increase in the left ventricle end-diastolic pressure and compression of the subendocardial coronary arteries, leading to myocardial ischemia, which will be manifested in the form of chest pain. And on the long run, it may cause fibrosis and trigger arrhythmias as well. And of course, all the previous symptoms may trigger sudden cardiac death. After that, I will discuss the pathophysiology of aortic coarctation. Actually, aortic coarctation may have 2 different presentations. Imagine with me that this is a fetus in utero. He has aortic obstruction, aortic coarctation. Here there is obstruction to the flow, yet he had another associated congenital anomalies. For example, this large VSD. So the left ventricular output, because of presence of obstruction here in the aorta, will prefer to go to through the VSD to the RV, pulmonary artery, PDA, and will fill the descending aorta. And this will lead to gradually small LV in utero in the fetus. So after birth, shortly after birth, after closure of the PDA, the patient will not be able to maintain flow to the descending aorta and will enter into circulatory shock. And this is the presentation of critically ill neonate with aortic coarctation. Yet in the other patient, this is also a fetus in utero who have aortic coarctation, yet he has no other associated congenital anomalies. So the left ventricular outflow will go through the aorta, and because of this obstruction, it will gradually form collaterals. So after birth, when this PDA closes, this aorta will be able to maintain flow to the descending aorta through the already formed collaterals. And this neonates may be passed unnoticed and be asymptomatic, and even they may be discovered in adulthood with just systemic hypertension. And these are the 2 different presentations of the aortic coarctation and their pathophysiology. Following that, we will start with cases. Each case will discuss a level of obstruction of the left side. We'll discuss it together. Any questions in this part? Any comments?
So we have a question from our colleagues on YouTube.
Okay.
So asking about Shone complex, supramitral ring,
Yes.
and what's the difference between that and coarctation? I believe you're going to discuss that later.
Yes, I will discuss it in a separate slide. So
Okay,
let's wait.
So wait till we reach that.
Yes.
Another question about difference between subaortic membrane and fibromuscular ridge. Also, I believe you. Yeah. So everybody is really anxious to get to the rest of the presentation.
Okay. That makes me very happy.
Thank you, Yasmin. Go on.
Okay. Our first case is a 13-year-old male, which means that he is an adolescent. To summarize, the adolescent is the period between the puberty and adulthood. So we have an adolescent with lower limb claudication pain on moderate exertion. He has progressive dyspnea and claudication started 1 year before presentation. He already have past history of aortic coarctation at age of 5 years with irrelevant family history and perinatal history. So we have a patient already known to have aortic coarctation who had surgical repair for it at the age of 5 years, but now he is coming to us symptomatic and he is an adolescent. He's 13 years old. On examination, he had, of course, left lateral thoracotomy scar of previous aortic coarctation repair. He has upper limb hypertension. He was uncontrolled. It was 190/90 bilateral. He had weakly felt lower limb peripheral pulsations with forceful apical pulsations in the left fifth intercostal space at the mid-clavicular line, which means that he has no dilated dimensions, as the left fifth intercostal space is the normal place for the apex, but he has a forceful apical pulsations. He had also ejection systolic murmur grade 2/4 all over the precordium and in the suprasternal area. So what is relevant in that examination that he has uncontrolled arterial hypertension, and also he have a weakly felt lower limb peripheral pulsations. Fortunately, the patient had his multi-slice CT at the age of 5 years old. That was before his surgical repair. It shows us subaortic coarctation. We can see here how severe his aortic coarctation is. We can see also that he has a bovine arch. You can see that the first grade vessel is giving origin to the innominate and right common carotid, and then that is the left subclavian artery.
An impressive image, Yasmin.
Yeah, I was impressed with the fact that he got the
we can see the very large arteries going anterior. These are the internal mammary arteries, which are supposed to be really small, much smaller than that. But as you say, with that severe obstruction, collaterals start to develop, so that blood can pass from the upper half of the body into the lower half. The internal mammary arteries are one of the major collaterals that develop, in addition to the posterior intercostals and others.
Yes.
Quite impressive.
Okay. That was his ECG. Unfortunately, there's overlapping of the ECG strips, but I think it shows LVH. There's LVH by voltage. As for his chest X-ray, it's very interesting. We can see here that his his dimensions, his cardiac dimension is not dilated. He has normal size of the heart. At the case of, that's usually encountered in patients with aortic stenosis and aortic coarctation, that dimensions are not dilated except at very late stages of the disease. We also can see here rib notching. You can see it here, and you can see the figure of 3. It is because of the post-stenotic dilatation in the descending aorta and you can see some surgical marks here of his surgical repair. Okay. That was his transthoracic echocardiography. This is a parasternal long axis view. You can see he has a good systolic function, LVH. His aortic valve is normal thickness. Also, mitral valve looks normal. You see that we must revise every level of obstruction in a patient on the left side to be sure that there is no other level of obstruction in the left side. Here we can see the parasternal short axis view with good systolic function, LVH, and also you can appreciate this normal mitral valve. This is an M mode in the LV showing normal systolic function, LVH, and normal internal dimension. The left ventricle diastolic dimension only 44 and systolic 26. This is his apical 4-chamber view. Good systolic function, LVH, normal right side size, normal mitral valve morphology. And this is his suprasternal view and Doppler examination of flow into descending aorta. We can see here increase of the velocity till with pressure gradient of 50, but there is something unusual in this view. Would you like to leave it to the audience to comment? What is unusual for a patient with aortic coarctation with already increased gradient in this suprasternal view? Yet
So
he has.
shall we get answers on the YouTube chat?
Yes, please. I think we can leave it for vote just for 1 minute because it's very nice.
Okay. It was weird to find this Doppler flow, yet there is increased velocity, increased pressure gradient, but there's something missing to be sure that this is coarctation.
So shall you continue with the case until we get some answers?
Okay.
And then we come back to this image.
This flow is weird a little bit. I had to make sure that patient has a significant aortic coarctation by echocardiography. So I had to investigate flow in the descending abdominal aorta. Here, in normal patients, you should see pulsatile flow. It will be in red in the same direction, but in this patient, you can see this is a continuous flow, similar to the venous flow. Any arterial flow should be pulsatile, but this is continuous flow, and this is what you see by Doppler.
So I've got some answers from our colleagues. 3 answers that there are no diastolic tear or no diastolic runoff.
Excellent. Absence of diastolic tail makes us not sure that this flow is typical of aortic coarctation. So we have a question here: why patient had a clinically significant aortic coarctation proved by this image? Yes, he has no diastolic tail. Till now we had no answer. We will see after that the answer to that question, why we don't have a diastolic tail. Maybe the answer is here. This was the multi-slice CT he did. We can see the single grade vessel that the patient have, giving rise to the innominate and the right common carotid arteries. Already the patient had the left subclavian artery taken down for the repair of his aortic coarctation. And here you can see that the arch is significantly diffusely narrowed. It's not a typical focal aortic coarctation at the site of aortic isthmus, as he already has a previous surgical repair. That was the, you can name it arch coarctation, diffuse narrowing in the arch, and which is challenging for us.
So taking down the left subclavian artery is one of the technique that is well described for for the repair of aortic coarctation.
Actually, I will need you to talk about different techniques in
Okay, that's great.
an isolated slide just now, because we want to say that native aortic coarctation, the standard treatment for native aortic coarctation is surgical repair. That's what our patient had at the age of 5 years. Hopefully the slide with the surgical techniques is coming. First, I will discuss how would we manage this patient. I will summarize the case. He's 13 years old, adolescent. He's symptomatic with claudication, with upper limb hypertension. He had LVH with echo pressure gradient across the aortic arch and descending aorta 50 millimeter mercury, which is significant gradient, and multi-slice CT showing and significant narrowing of the arch. And according to American Heart Association guidelines, it's a class 1 indication for balloon angioplasty for recoarctation in patients with pressure gradient more than 20 millimeter mercury across the coarctation segment, or if you have a pressure gradient less than 20 with impaired systolic function, or in a univentricular heart, or patient with significant collaterals, underestimating the pressure gradient. Also, it's a class 1 indication for stenting, especially if you can dilate your stent to the adult size later. Actually, this patient was tall. he was almost taking his adult size. And this is the slide I wanted Dr. Hatem to tell us different techniques for surgical repair of native aortic coarctation. Okay, Dr.
So there are different techniques for repair of aortic coarctation. They include some simple techniques like just cutting out the coarctation segment and connecting them directly together, which is resection and end-to-end anastomosis, which is the image on the right upper hand. So yes,
okay,
quite obvious. You just resect the narrow segment and connect the aorta together. A simple technique, but there is a high risk of recurrence. One other technique is that you take down the subclavian artery, like that case. So mobilize the subclavian artery and cut it as distal as possible, and then open the subclavian artery across the coarctation, and then you can see coarctation shelf there, which many surgeons tended to resect that coarctation shelf, and then put either a patch or use the subclavian artery directly to put that. A big problem with resection of the coarctation shelf is that is associated with high incidence of aortic aneurysms or pseudoaneurysms. And this is more common with putting patches, like patch angioplasty, like figure B. On the other hand, using the subclavian flap without resecting the coarctation shelf, this gets less incidence of aneurysms or pseudoaneurysms and less incidence of recurrence. But obviously, we sacrifice the artery going to the arm. This is very, very rarely associated with ischemia, but it's more related to the growth of the arm. So usually that arm does not grow normally like the other arm, but this is an area of heavy collateral flow. So usually the arm is supplied well with no ischemia. Again, this has started coming out of fashion now, since there are other techniques. One other technique is extended end-to-end anastomosis, so also resection, like when we do figure A on the right upper hand, and then an incision is extended along the undersurface of the aortic arch, and the counter incision is extended along the dorsal surface of the descending aorta. so that the opening now is so much larger. And then the descending aorta is anastomosed nearly to the proximal arch. And so as if the arch and the descending aorta are slided over each other. This has been associated with much less risk of recoarctation and other problems. So currently, if a small kid presents with an isolated discrete coarctation, usually the procedure of choice is the resection with extended end-to-end anastomosis rather than direct end-to-end anastomosis. If a patient is bigger size, so I mean approaching adult or approaching bigger size, usually the first choice would be cath and stenting, exactly like Yasmin said, because now we're approaching adult size aorta, so an adult size stent can be put. But if anything prevents that, one option in adults can be interposition graft, where we resect the coarctation segment and then put a tube graft. We need to put a tube graft that is big enough so that when the patient grows, it doesn't become narrow for him. So we don't usually do that in the very young kids, because otherwise the coarctation would be very small. The graft would be very small when he grows older. There are other techniques, but these are the most common ones used. So if a native coarctation isolated with no other lesions, usually surgery is from a thoracotomy on the side of the arch with extended end-to-end anastomosis.
Sorry for the interruption, Hatem. Thank you so much for an elegant illustration for the surgical techniques. You have just mentioned that the recoarctation is more common in the subclavian flap angioplasty. I have questions for both.
It's more common in the resection with end-to-end. So this was the most common type of repair associated with the recoarctation. Obviously, recoarctation can happen in any techniques, even with the extend end-to-end. But I mean, some complications are more common with some techniques more than the others. But all these problems actually do happen.
Okay. So what are the pros and cons of each technique, and which technique which has a highest incidence of recoarctation? And I would like to hear from you and Yasmin about the overall incidence of recoarctation.
So the most common complication with the direct end-to-end anastomosis is the recoarctation. Most common complication with the patch angioplasty is the aortic aneurysms or pseudoaneurysms, either related to the patch or most commonly in the native aortic wall just in front of the patch. Okay. Problems with the subclavian flap has been related to limb growth. Sometimes still aneurysms can occur or recoarctation, but it is more related to the limb growth. Problems with extend end-to-end anastomosis, you can still get recoarctation, although the incidence is much less. The problem with extend end-to-end anastomosis, if you do that in a patient who actually has a significant narrowing on the aortic arch, because this is usually not enough. So you can get recoarctation not at the site of the repair, but actually a bit proximal to it if the aortic arch was hypoplastic to start with. So this needs proper attention, because then you'll need to do a different technique, probably from a sternotomy with arch repair, different techniques in that. There are some complications which can happen with any types of techniques. Famous ones are the recurrent laryngeal nerve injury. Usually is a self-limiting and usually unilateral, so most patients are not very much affected with that, but the recurrent laryngeal nerve is very near. Some patients can get chylothorax. The drastic complications here are the paraplegia, which is sadly it is permanent. It doesn't improve with time, and it is related to the blood supply of the spine during the duration of the clamping of the aorta during the repair.
Yeah.
So this is a really worrying thing. Other complications of surgical repair is post-operative paradoxical hypertension and the associated gut ischemia. So this can lead to significant gut gangrene, which requires a lot of bowel resection, and this is really a serious problem. Sorry, Sarah, I interrupted you.
No problem, Hatem. I have a question about surgeries. Do you think that the expertise of the surgeon can influence the rate of recoarctation, or it just depends on the type of technique and the anatomy?
I believe both, Sarah. So yes, the technique does affect the incidence of recoarctation, but on the other hand, this is an operation that requires experience and familiarity, because most of the time it is being done from a thoracotomy with no support on bypass. So significant bleeding can happen, or if it is not done comfortably, can cause narrowing or other complications that I've just mentioned.
Regarding the follow-up, does it change because of the type of surgery that you decide to use, or it is standardized for each type of surgery? Yasmin, your experience about the follow-up in this kind of surgeries, is it the same, or does it vary with the type of surgery that it's used?
Yasmin, the question is yours.
May you repeat it, please?
About the recurrence after operation?
Yes, I was wondering about follow-up, if it is influenced by the type of surgery, or it is standardized by for each patient, and how do you do it in order to prevent the recoarctation?
Okay, usually follow-up depends on the initial results that we see after surgery. Patients with satisfactory results, usually we follow every year or even every 2 years, and very satisfactory results. If results are not satisfactory, we can shorten the period of the follow-up, make it every 3 months or 6 months, according to the case, according to every case.
Okay, thank you very much. For this case, just another question, sorry, it was very, very interesting. I was wondering why the patient had the first surgery at 5 years old. Was the diagnosis missed when he was born, or because there were something else that permitted the patient to arrive to 5 years old?
According to the history from his relatives, he was missed in the neonatal period and in early childhood. Then he started to complain of some headache.
Okay.
They discovered that the arterial hypertension. He was investigated, and then they discovered that he has an aortic coarctation at around the age of 4 or 5 years old, not earlier than that.
Okay. In your experience, do you see a lot of cases of not diagnosed coarctation, or have you ever seen an adult patient with no diagnosis of coarctation, or is a very rare case?
We see usually some patients in the neonatal period in a form of critical aortic coarctation. Others are seen later, like this patient that we are showing during early childhood, at the age of 4 or 5 years old. And I think all my colleagues see a significant number of patients that reach till the adulthood and have discovered the aortic coarctation just because of arterial hypertension, or accidentally discovered the LVH during echocardiographic examination. That's why every patient or patient that have unexplained systemic arterial hypertension in their 20s or 30s with no family history of familial hypertension should be investigated for aortic coarctation. For example, if you are doing a transthoracic echocardiography for a young adult with hypertension, complaining of hypertension unexplained, you should look in his suprasternal view and investigate well if he has a narrowing in his descending aorta or not. Even you can get his view to his descending abdominal aorta to be sure, or you can simply examine his lower limbs for the peripheral pulsations.
Thank you very much for sharing your experience. There is just
sorry. Regarding the flow in the descending aorta you just mentioned, would you explain the diastolic tailing? We got a question about that. Would you explain what does the diastolic tailing in the Doppler means?
Okay, here we have in this diagram, we can see the aortic coarctation. So diastolic tail is maintenance, that the antegrade flow to the descending aorta is maintained during diastole. Normally, we have antegrade flow during systole, and there's no other antegrade flow during the diastole. Yet, in the patient with aortic coarctation, we have maintained antegrade flow during diastole, which gives us the diastolic tail.
Yeah.
That's because of the obstruction, and that the blood flow continues to enter the descending aorta during diastole.
So the pressure in the ascending aorta is still higher during diastole, diastole. So because of the obstruction, so it continues to go during the whole cardiac cycle.
Yes.
Thank you very much. Very elegant explanation. Thank you.
Okay, that was we saw when we took the patient to our cath lab. This is a rotational angiography. I'll make it stop here to see. You can see here how much the aortic arch is narrowed with post-stenotic dilatation of the descending aorta with transcatheter pullback pressure gradient of 30 millimeter mercury, which is significant in measurement of pressure gradient across the aortic coarctation inside the cath lab. Pressure gradient more than 20 is a significant pressure gradient and is an indication for intervention. Actually, it's not a straightforward case. It's not a focal obstruction, also encroaching the single grade vessel that the patient has. That was with 3D reconstruction. I will explain. This is the bovine aortic arch with the first grade vessel giving the innominate and right common carotid artery from a single origin. And this is the left subclavian artery. But this left subclavian artery in our patient is taken down for repair of the coarctation. So that's what the patient have. There is narrowing, and this narrowing is encroaching the origin of the single grade vessel that the patient have with significant post-stenotic dilatation. And we decided to give him a chance with transcatheter intervention. This is a summary of the challenge that we have. Of course, he is a recoarctation following surgery. He has increased risk of rupture, dissection, aneurysm formation. He has, of course, surgery for him is of high risk. There is a diffuse hypoplasia in the arch rather than focal coarctation. It's nearby the single grade vessel patient have. Is also the curvature of the arch makes it challenging in stent placement, but we decided to have this challenge. Thank God he had a nicely placed covered stent. In these patients, we prefer to use covered stent due to high risk of dissection or aneurysm formation of previously repaired coarctation.
What do you mean covered stent, Yasmin?
Covered stent, which has a polytetrafluoroethylene cover inside it. It's not it's not open cell. It makes like enforcement to the wall of the aorta. It may heal any dissections that may happen during deployment of the stent.
Also, so other stents that are not covered are, as you say, open cell. So you can pass, the blood can pass through it.
Yes,
but with the covered stent, it's like a tube graft mounted on a stent. So when you open it, if there is any leak, it gets sealed.
Yes, it seal any leak. But fortunately, it's the distal cells usually are not covered. And this is very good in our case, as the distal cells are in contact with the origin of the great vessel. Okay?
Yeah.
covered stent do not allow flow to side branch of the aorta if they are placed across. Only the distal cells are not covered, and this was very nice in our case. Fortunately, the patient had a pressure gradient across his stent of about 5 millimeter mercury, which is a very good result. And I want now to discuss the post-catheterization care of such patients. He was kept on dual antiplatelet therapy, and of course, prophylaxis against infective endocarditis. He had marked improvement of his symptoms, but he had persistent systemic hypertension, and he was kept on antihypertensive treatment in the form of beta blocker, which is the best antihypertensive for cases of aortic coarctation. I want to say here that not all patients who had their coarctation treated are cured from the systemic hypertension after. It was found that the later the repair of the aortic coarctation was done, the more probably the patient will still to have a systemic hypertension and will need to maintain his medical treatment for it. And of course, patient must know that he will have a lifelong follow-up with multi-slice CT, maybe according to his case from every 3 to 5 years to detect any stent fractures, aneurysm formation. He should be followed up, and he will have a lifelong follow-up.
I think this is very important, Yasmin, mentioning that the later the repair, patients will stay with hypertension. It doesn't resolve completely, which means that irreversible changes occur in the vascular bed of these patients because of the very high pressure before the repair. So,
they are more prone to coronary artery disease, for example. It's a risk factor for coronary artery disease, hypertensive
and
heart
stroke, cerebral hemorrhage, as exactly as you say. So, if a patient presents at 1 year of age, has significant coarctation, yet he's asymptomatic, would you recommend doing the repair or waiting and following up?
I think we should go and repair it.
We should go, otherwise you get the secondary change and you do not get back to the vascular bed.
Yes, we should. Would you like to go to the...
Yasmin, for interruption before going to the tracing, your excellent case raised a lot of questions from the audience. And I think we have 2 questions. The first one about the use of covered stents versus pair stents. When do you prefer to use the pair stent, and when do you prefer to use covered stent? And the second question about stenting itself. Is it the standard of care in recoarctation after surgical repair?
Okay. As for pair stents, we prefer it in case we have side branches. We want to maintain blood flow in this side branches after deployment of our stent. For example, if origin of left subclavian artery is involved, we should use a pair stent. But if we don't have side branch and the patient is at high risk of dissection, aneurysm formation, so we should go for a covered stent. That is the main difference.
Okay, so using a covered stent is more preferred than using a pair stent, unless you have a branch arising from the stenotic segment.
Yes.
And fortunately, in this case, the subclavian was taken down during the previous surgery, so you didn't go through this dilemma.
Yes, post-surgical patients at our high risk of dissection, aneurysm formation, so we prefer to have a covered stent.
Okay.
As for the stenting for recoarctation, yes, it is the standard, it's class 1 indication. The balloon dilatation and stenting is class 1 indication for recoarctation, for patients with recoarctation, especially the stent, in case you can be sure you can dilate it to the adult thighs later, if the patient is an adolescent, for example.
So can you dilate the coarctation at first while the baby is still like 5-6 years, and then when he grows older, can you further dilate that?
Yes, yes, but it always carries the risk of dissection or aneurysm formation, as small cracks may happen in the intima or media of the aorta. You cannot guarantee that you will not have a dissection or later aneurysm, slowly progressive aneurysm formation. It's not preferred.
I see, and I agree. The post recurrent, I mean the recurrent coarctation post surgical repair should have so the stenting should be first choice. Here the operation is significantly more difficult. Repairing the coarctation requires a lot of mobilizing the arch and head vessels and descending aorta and getting that together, especially with the sliding the extend end to end. So this is a bit more difficult when there are adhesions. On the other hand, I believe the stenting here is safer because the adhesions around the previous operation decreases the risk of getting dissection or rupture. But obviously, as you say, if you use covered stent, this even gets further low.
Nice hearing this from a surgeon. You did a great job, Yasmin.
Okay.
Then I got used to this. So there was a quick question about why gut ischemia. So
flow to descending aorta. I think during surgery you have prolonged the bypass. And
yeah, but on the other hand, a big problem that occurs post surgery is the paradoxical hypertension, which is we don't want to take too much time here, but the baroreceptors in the arch and the neck vessels are accustomed to really high pressure, so that blood flow through collaterals will be sufficient to the kidneys and the gut. And so immediately after the operation, the blood pressure should have gone down because the obstruction now is relieved. But on the other hand, when the pressure goes down, the baroreceptors feels that the body is in a shock state, and now the collaterals are not sufficient to the kidneys. So it causes severe widespread vasoconstriction in the whole body, which gets the whole body blood pressure into really high numbers, 170, 200, which is very injurious to the gut vessels, which were accustomed to a pressure of 40, 50. And now they suddenly are exposed to pressures of 200. So severe arthritis occurs in the blood vessels of the gut and can cause significant gut ischemia and gangrenes, which might require a lot of bowel resection, which is a really serious problem. So the very important message here is aggressive control of blood pressure after the coarctation repair, because otherwise significant complications can happen. Thank you, Yasmin.
Actually, I remember now that I forgot to say that a patient should be kept NPO, nothing per os, after this coarctation stenting. And this, like what Dr. Hatem said, that we should keep our patients with NPO, nothing per os, after this coarctation stenting. And of course, this happens after surgery.
So feeding is related to gut rest and the problem of gut ischemia, but also can show us the chyle leak into the tube, where after feeding, patients can get chylous effusion draining into the chest tube. So the feeding is can indicate any of both. And as you said, gut rest is helpful here. And the important thing is that we noticed that the patient can move his legs because of the drastic complication of the paraplegia.
Actually, Hatem reperfusion entry happens also after stenting, but with a less stent.
Yes.
Okay, let's move to the second case. Oh, it's just a tracing in order to take some rest from cases. Here we had a previous question about the difference between a tunnel subaortic obstruction and focal discrete subaortic membrane. These are TEE views. This one is at the left ventricular outflow, mid-esophageal degree at an angle 120. We can see the left ventricular inflow, outflow with a long tunnel of subaortic obstruction. Here you can see the muscle and the narrow LVOT. There is also, you can see that the patient has a relatively small annulus, and this is usually associated with the tunnel subaortic obstruction and a thickened aortic cusps with restricted movement. And by color, you can see that there is a gradient or turbulence in the antegrade flow, and also retrograde, which is aortic stenosis and aortic regurgitation. The aortic stenosis that is in red and the other one is relatively in green. This aortic regurgitation is a complication to the of the subaortic obstruction, which causes blood turbulence. This causes thickening of the aortic cusps and resulting aortic regurgitation. Also, in this patient, he had systolic anterior motion of the mitral, of the anterior leaflet of the mitral valve, causing, you can see in this view, significant mitral regurgitation. This is the tunnel subaortic obstruction. It's diffuse, usually associated with relatively small annulus and may be associated with aortic valve stenosis. Yet in the second slide, I will show you this is a subaortic membrane. This is a focal obstruction. You can call it discrete. Here it's membranous, more membranous in character. Here fibromuscular, there is a muscular component in this membrane. Also, this subaortic membrane causes gradient in the LVOT. It causes turbulence of flow, which causes thickened aortic cusps and secondary aortic regurgitation, which should be followed up because mild degree of aortic regurgitation alone is an indication for surgery. When you see a subaortic membrane in your practice, you must mention its distance from the aortic cusps, gradient it causes, presence of aortic regurgitation or not. I think Dr. Hatem may also tell us what the significance of its distance from the cusps. It's not very clear to us as echocardiographer. You can tell us?
So exactly as you said, subaortic membrane can cause significant deterioration of aortic valve function. Some of that is related to the turbulent jet that hits the cusp, but more often, the fibrous membrane can creep into the aortic cusp themselves and cause them to be retracted and prevent opening and closure. If that is heavily involved, peeling out of the membrane from the aortic cusp can be actually difficult and really dangerous, because aortic cusps can be really injured during peeling off of the cusp of the membrane. While on the other hand, if you leave them, you usually get recurrence. And so we hope that we take out the subaortic membrane as early as possible before any affection of aortic valve function. We don't want to know the distance so that we know where to take it out, because we can see them directly. But on the other hand, it gives an impression about the difficulty of the operation and how affected is the aortic valve. So then the closer to the aortic valve, the more the difficult the operation. Also, we tend to avoid recurrence because this is a lesion which is also associated with recurrence after resection. So the incidence of recurrence becomes less if, in addition to complete resection of the membrane, we also do septal myectomy. So we take out a part of the muscle of the septum so that the LVOT will become wider, so less turbulence, so less recurrence. But on the other hand, this resection is not an easy thing to do. You can take too little, so you don't relieve much of the obstruction. But on the other hand, if you take too much, you can cause VSD, or if you take in a wrong area, you can cause heart block. So this needs a bit of experience.
Okay, thanks, Dr. Hatem. I will summarize in this slide much of this information already we mentioned. Indication for intervention is in subvalvular aortic stenosis if the patient have a gradient more than 50 millimeter mercury. It's class 1 indication. Aortic regurgitation, once you have mild aortic regurgitation, it is an class 1 indication for surgery, as aortic regurgitation is progressive. It's well known that it is progressive in this course of this disease. Patients with gradient 30 to 50 is class 2B indication. Although it's mentioned in literature that a gradient more than 35 millimeter mercury is an indication for intervention in subaortic membrane. Is that?
Yes. I just want to ensure here that everybody notices that we're talking here about peak gradient, not mean gradient, because the indication for surgery for aortic valve disease, aortic stenosis, we talk about 40 millimeter mercury of mean gradient. Well, this is peak, so this is much less gradient. Obviously, because dealing with aortic valve is more difficult, and having to sacrifice aortic valve for aortic replacement is a big thing to do, while here is a relatively safer, because you take out the membrane while preserving the aortic valve. And as you said, the longer we wait, the more damage that happens to the valve. So we tend to intervene earlier in subaortic stenosis than valvular aortic stenosis.
Although the threshold for doing the subaortic membrane is much less than the other types of aortic stenosis, however, we see a lot of surgeons who would prefer to postpone surgery till an older age because of the higher incidence of recurrence. Do you have any explanation for that from the surgical point of view?
So obviously, when the patient grows older, the operation is easier, and will be able to see better and do more complete resection. But on the other hand, if you wait too long, you can the aortic valve function can be significantly affected, and in many cases, this affection of valve function will not be reversed after the operation. So we tend to preserve the valve and try to protect it, even if we'll have to intervene later. But again, 2 operations with an intact valve is much better than 1 operation with a valve replacement. Then you keep replacing that valve the rest of the life.
Okay. In tunnel subaortic obstruction, peak pressure gradient more than 50 millimeter mercury is an indication for surgery. As we mentioned before, that there is a recurrence 25% in such cases. Usually we think, why didn't the surgeon excise the membrane or did more and more myomectomy? And as Dr. Hatem said, more myomectomy and more aggressive resection may be associated with heart block or iatrogenic VSD. And surgical treatment is usually in the form of, can be in the form of cono procedure in case of small aortic annulus in order to widen the aortic root, or a combined Ross cono procedure in case of diseased aortic valve as well, combined with the subvalvular aortic stenosis. The other case, or would you like to have some discussion?
Go on, Yasmin.
Our second case is a 10 days old neonate. He's 3 kilograms. He presented to us with inability to maintain suckling, difficult breast and bottle feeding. he started in these symptoms started in the 5th day after birth. He had there was his parents had no consent, there was no non-consanguineous marriage. His mother stated that she had pre-eclampsia, delivered at 38 weeks of gestation. He's the 4th in order of birth of 2 living sisters. His elder brother died at the age of 6 months from unknown cause. So we have a neonate, 10 days old, 3 kilogram, presented to us with difficulty in feeding, which started only in the 5th day after birth, and a history of an elder brother who died at the age of 6 months old. On examination, he had neonatal jaundice. His serum bilirubin was 11 millimeter mercury per deciliter. He had a tender right hypochondrium with good urine output, normal kidney function, and no sepsis. He had no cyanosis with soft pansystolic murmur all over precordium. He had an RV tap with no thrill. In this age, it is expected to have an RV tap, as still there is RV dominance. We mentioned that he had a tender right hypochondrium, which means that the patient is in failure, but he had good urine output, so he is not in a shock, in circulatory shock. And he had also neonatal jaundice. So we'll think the patient 10 days old, he has heart failure, he has acyanotic heart disease. It may be either a shunt lesion or an obstruction. Shunt lesion causing volume overload and persistent pulmonary hypertension causing the persistence of RV dominance, or an obstructive lesion. I wanted to mention that we have one item missed in his examination that will help us to reach the diagnosis, and I want to say that we must examine the peripheral pulsation in such patients. He had a faint femoral peripheral pulsation and absent popliteal and posterior tibial peripheral pulsation, and that was the clue. This was his ECG. He was slightly tachycardic, with heart rate around 180 beats per minute. We can see in V1, V2, the RV dominance, tall R denoting RV dominance. That was his chest X-ray. We can see here enlarged cardiac shadow, left apex denoting dilated right side, upturned apex, and this is dilated right atrium. His chest X-ray is very soft, but I can see here prominent pulmonary vascular marking. Okay. And that was his transthoracic echocardiography, apical 4-chamber view with markedly depressed LV systolic function, dilated hypertrophied RV with preserved systolic function, dilated right atrium. So when you encountered such a patient with markedly depressed LV systolic function, search rapidly for aortic stenosis, coarctation. What caused this markedly depressed LV function? This is his tricuspid regurgitation, moderate TR with elevated right ventricular systolic pressure denoting persistent pulmonary hypertension. This is a biatrial view. He had an associated ASD, high secundum ASD. after that he had sinus venosus, associated sinus venosus, ASD, and this is parasternal short axis view showing his markedly depressed LV function and dilated hypertrophied RV with good systolic function. That was his suprasternal view with Doppler flow showing the diastolic tail we mentioned before, which is persistence of antegrade flow during diastole. Yet you can notice that the pressure gradient was only 34 with markedly depressed LV function. Marked depression in the LV function caused this underestimation in the gradient across the aortic coarctation, but this Doppler pattern shows you that this patient has a significant coarctation. Would you like to summarize the case before or have any discussion?
Yeah, have a question for you about the case that it's quite interesting, in particular for the age of the patient. Does it did a fetal echocardiography for some reason, or there were pre-diagnosal exams in this case or not?
Yes, his mother should have done fetal echocardiography because she has a history of a previously unexplained death of her child at the age of, I think it was a few months. She should, this is one of the indication of fetal echocardiography. Yet in this patient, she didn't had any fetal echocardiography before delivery.
Okay, yes, I can understand. Yeah, I think that if she had done this echo, then the delivery will be organized in another way. Yeah.
Yes, and it will affect his management, and I'll mention later what would have he received if he was diagnosed to have a critical aortic coarctation before birth. We should have been, I'll say later now.
Yeah, okay, don't spoil anything. Okay, perfect.
A 10 days old neonate with critical aortic coarctation, symptoms of heart failure, markedly depressed LV systolic function, and according to guidelines.
Yasmin, may I comment here? So you're nicely showing us the other end of the spectrum. So in the previous case, you showed us a patient that was nearly asymptomatic or accidentally discovered because of headache, showing the hypertension. Some patients actually can grow into adulthood before getting diagnosed. So this is one end of the spectrum with focal coarctation with well-developed collaterals, and patients can grow quite well on that. But on the other hand, as you just showed us, neonates can present in a really bad state with heart failure, markedly impaired LV function, sometimes into circulatory shock with acidosis and oliguria because of tight severe obstruction before development of any collaterals. So these are the two wide end of the spectrum in the aortic coarctation. So yeah, so go on, please.
As we mentioned before, the treatment of native aortic coarctation is surgical. It's class 1 indication to do surgery for such patients. It's class 1 indication. Yet, in case of critically ill neonates who have a high risk for surgery, presenting with severely impaired left ventricle systolic function, balloon angioplasty is a class 2A indication, usually preferred to tide over this crisis and help the patient to be fully compensated before entering into his surgical repair. Would you like, Dr. Hatem, to mention if you encountered such a patient in your practice with this impaired function, neonatal jaundice in heart failure? Would you like to wait a little bit, or you would like to give him the definitive surgical treatment?
So honestly, in such a case, if a patient presents with impaired LV function while he is still well perfused and in a relatively good condition, I would consider this as an urgent surgery and do it directly without waiting. On the other hand, sometimes we see patients who are really, really sick. So they are on mechanical ventilator, on high inotropic support with acidosis and oliguria and really bad state. So in that case, I think there is a very good case for balloon, so that we know that the balloon can get quick relief and improve the condition. Although there is a high incidence of recoil, so we know that this is not a definitive procedure, but it can improve the condition of the patient till we get him to in a state that he is more fit for surgery. In such a case, I would rather prefer surgery. But on the other hand, if he is very, very sick, I see a good case for balloon here.
Do you have a lower limit for weight and age for such patients?
So this is center experience and institution protocols. So different centers have different protocols for that. But in many centers, they would accept patients who are 3 kilos or even slightly lower to do it directly without staging.
Thank you, Dr. Hatem. Actually, in this
obviously,
case,
the younger the patient, the more incidence of later recurrence. But on the other hand, and obviously it is a more technically challenging operation. But I mean, if the center and the whole team experience, I mean, with surgery, with the anesthesia, intensive care, and management of that, if a neonatal center is accustomed to doing that, I think this is perfectly valid.
Okay, thank you, Dr. Hatem.
Yasmin, before going to the management, we have a question from Dr. Hagar Mustafa from the YouTube about the pathophysiological explanation of the severe LV impairment and a markedly dilated RV. I think the confusion in the examination is about the explanation of the RV dilatation.
The RV dilatation, here you have a back pressure. You have an obstructed LVOT, markedly increased left ventricle systolic pressure. So this is causing a back pressure from the left atrium to the pulmonary vein, pulmonary venous congestion, and secondary pulmonary hypertension in these patients. So patients, critically ill neonates with coarctation, present also with pulmonary hypertension. When you are examining a neonate and you encounter pulmonary hypertension unexplained, don't forget to check your suprasternal view, check if the patient have aortic coarctation or no. Sometimes the views are difficult. You can't see the descending aorta clearly. So simply examine the lower limb pulsations or see by Doppler the flow in the descending aorta.
Also, it's not rare to see patients who present with severe impairment of LV function and actually get diagnosed as dilated cardiomyopathy. And this is a very, very different diagnosis, because patients with dilated cardiomyopathy, there's essentially no intervention that can be done for that, at least in the very young, at least again in our population.
And
so
I think as Yasmin just mentioned, here comes the importance of assessing the flow in the descending abdominal aorta, putting a Doppler on the abdominal aorta and assessing the flow.
So a rule of thumb here is to remember, if an infant presents with severe impairment of LV function and you're about to diagnose dilated cardiomyopathy, you should not do that diagnosis without excluding coarctation, L-kappa, and atrial tachycardia, because these are diseases that can be treated and the patient can actually improve very well, which is a very, very different diagnosis than having a dilated cardiomyopathy, which is, and now we start thinking transplantation or VET support, which is not usually available in such young age.
Okay, thanks a lot.
So coarctation, L-kappa, and atrial tachycardia.
I think we have another question about the issue of the assessment of flow in the descending aorta. Where should we put the pulse Doppler in the descending aorta?
Okay, you can, from the subcostal view, just below the xiphisternum, you can investigate to see the aorta from the subcostal view, the aorta and the IVC. Then you will use a longitudinal view of the aorta with color flow and pulse Doppler. You can easily evaluate your flow by Doppler.
Do you assess the flow in the descending aorta itself or in one of its branches, like the celiac artery?
If you can't see the descending aorta, maybe, but I think descending aorta is much easier.
The preferred is descending aorta. It's much easier to get a flow parallel to the descending aorta.
Yes, yes.
Thank you so much, Yasmin, for your explanation.
Okay. So also agreeing with the Indian guideline that it's class 2A and it's reasonable to pass this critical situation with your patient with transcatheter balloon angioplasty in order to allow patient later to have surgical repair, his definitive surgical repair for this coarctation. So we took the patient for urgent cardiac catheterization. Of course, we needed a lot of preparations. He is a high-risk patient. We need high-risk consent. He's a neonate, needs good neonatal care. Patient has neonatal jaundice, and the first line of treatment of this neonatal jaundice was good hydration, which was difficult in presence of this heart failure, decompensated heart failure, and markedly depressed LV function. He needed a very meticulous fluid balance in order not to have his bilirubin levels elevated. We should take care of blood loss, especially during the puncture. It will not be easy in such a small baby with aortic coarctation. Of course, an anesthesia team should be prepared with his positive inotropes, and we should be prepared with our equipments. This was his angiography descending aorta. We have our catheter in the descending aorta in lateral view. I wanted to show you how severe was his coarctation. We managed to pass with a PCA wire, followed by dilatation by the catheter itself didn't pass through the coarcted segment. So we had to pass a PCA balloon and dilated in order to allow passage of our catheter to investigate well this coarctation. That was how it looked. It is a long segment. This is the subclavian artery. And here you can see a long segment of aortic coarctation. It's not a focal narrowing. We used another loan, and that was the end result that we had. Of course, you should not go for more and more dilatation and induce more dissections or cracks inside the aortic intima and media. In some centers, they prefer to put a stent. Yet in our center, we prefer not to make it more difficult during his surgical repair. We only did him a balloon. We can see after that, while a patient was on table and before taking him out of the cath lab, that was his left ventricle systolic function. And this is one of the benefits of presence of echocardiography inside the cath lab. You can see here improvement in his left ventricle systolic function. Also some pericardial effusion that should be followed thoroughly after the cardiac catheterization. Patient here was on Wotrex. We needed to put some inotropic support. This was his suprasternal view after cath. It showed us marked improvement. So we didn't proceed to more and more dilatation. And that was his new Doppler flow to the descending aorta. This was before cath, and this was after. You can see that the diastolic tail disappeared. We didn't start with a high pressure. We said because we have depressed LV function, yet the diastolic tail disappeared, showing marked improvement in his case. That was 24 hours after. We can notice that the pericardial effusion disappeared. It's very important to follow up this effusion, and marked improvement in his left ventricular systolic function. And now patient is not on Doputrex, thank God. Patient had markedly improved in his clinical condition. This is his LV systolic function.
So
an excellent,
a very go ahead.
Sorry, Adam, for interruption. An excellent bailout therapy for such a critical patient is mean. I think we have a question for both you and Hatem. We are expecting having an intimal cracks after balloon dilatation. For how long should you wait before sending this patient to surgery? And on the other side, Hatem, for how long do you prefer to wait on this patient till getting him to the OR?
Okay, I'll start. Sure, you will do some intimal and even medial cracks or injuries in this descending aorta. So try not to do any further manipulation with your wire and your catheter. Just if you had a good result, try to get away rapidly. In this case, I followed him clinically. I wanted to postpone his multi-slice CT in order to have him increasing in weight and also age to be to have an easier surgical repair. So I followed him for about a month. After that, he started to deteriorate again, and I encountered a re-increase again in the gradient across the descending aorta, and accordingly I did him a multi-slice CT. We'll see that later, but let us listen to Dr. Hatem's comment.
So if the patient had the procedure, I would just follow him up and reassess from the start. So if he's well and with no significant symptoms and no significant gradient, I just wait and consider him as a new case of aortic coarctation. So it's not like just we do the balloon so that we next day or next week we do the operation. If we've got good result with low gradient, we just follow him up. So maybe in month 2, 3. And then whenever he started to either get symptoms or get significant gradient, we then take him. But we should not wait so that he doesn't deteriorate again, because the aim of the balloon was to get him in good shape. So we have to do that in the good shape.
Actually, I'm very blessed having this harmony between surgeons and interventional cardiologists in our country.
Thank you, Khaled. Very clever questions.
Okay.
There was a really relevant question from Mahmoud Shahata, our colleague. So what do you think about the use of prostaglandins, prostaglandin E1? Do you think there is a role here?
Would you wait 1 minute? In this slide,
okay.
I will discuss his question and also the question previously Sarah asked. I mentioned in his symptoms that it occurred only in the 5th day after birth. Why this happened? This happened because that is the time where the ductus arteriosus closed. When we mentioned before in the pathophysiology of this disease, that this ductus arteriosus maintained flow from the pulmonary artery to the descending aorta. Once this ductus closed in absence of significant collaterals in the patient will develop circulatory shock. So if his mother had done a fetal echocardiography, would have been prepared with that diagnosis that the patient has a critical aortic coarctation. He would receive prostaglandin E1 once he was delivered in order to maintain patency of this ductus, to maintain flow to the descending aorta and protect the patient from developing or entering into a circulatory shock. And this is the
so that's very elegant and an on-time question. So on the other hand, so as you say, a prostaglandin can reopen the duct even if it actually closes, because usually in the first like few weeks, 3-4 weeks or so, the ductal closure is functional. So if you infuse prostaglandin E1, even if you do not see duct flow, you can open the duct. So the perfusion of the lower body will improve. On the other hand, if you believe in the ductal sling theory of the coarctation, maybe in some patients, the cause of the coarctation itself is that ductal tissue creeped into the aortic wall. And then when the ductus closed, also that caused narrowing in the aorta itself. So maybe infusing prostaglandin E1 can actually widen the aorta itself, regardless the opening of the duct. So yes, prostin is a beneficial of beneficial value here, and we usually use that in, as you say, in the critically ill patients with very low ventricular function or patients on inotropes.
Okay, thanks a lot, Dr. Hatem. Then after that, I followed the patient for 1 month after the cath, and I encountered deterioration in his clinical condition. So I referred him for a multi-slice CT, and that was his aortic coarctation, a long segment of tight aortic coarctation, and a hypoplastic arch as well, and also post-stenotic dilatation, and patient was sent to surgery to have his coarctation repaired. I think this is for this case.
So in that case, would you get the image again?
Okay. 1 minute. Okay.
So exactly as you say, very tight coarc, but on the other hand, the arch is hypoplastic, and very similar to the other case. Also, it's a bovine arch, so you can see that the origin of the carotid comes with the brachiocephalic. So in such a case, we would, at least in our institute, we would not do extended end-to-end coarctation. In such a case, we would go on bypass from sternotomy and do proper formal arch repair. There are different techniques for that. So some of that may entail direct anastomosis of the descending aorta into the ascending aorta with exclusion of the arch, or maybe opening of the undersurface of the arch and patch augmentation of there. Another technique was also the reverse subclavian flap. So people can divide the subclavian, and instead of reflecting that into the coarctation segment, actually reflecting that backwards into the arch, so that the arch is augmented. So different techniques for that, but this arch requires augmentation, and just dealing with the coarctation segment will leave him with significant residual obstruction.
Okay, thanks a lot.
Yasmin, more and more questions from the audience, a high flow of questions about the presentation and post the management. How does the site of coarctation, whether it is pre-ductal or post-ductal, affect the presentation and management decision?
Usually previously, we used to classify coarctation as pre-ductal or post-ductal. Yet now it's a periductal coarctation. It occurs in the site of aortic isthmus, which is just distal to the left subclavian artery and at the insertion of the PDA. And as Dr. Hatem mentioned, that it's a ductal, it may be a ductal tissue causing this aortic coarctation. We now classify the aortic coarctation according to the two pathophysiology I previously explained. Either there is collaterals and it's not that symptomatic, or there's no collaterals and antegrade flow cannot be maintained, and patients do not have significant flow in the descending aorta. That what makes the how we classify it, and not according pre-ductal or post-ductal coarctation. It's all juxtaductal. Okay. Other questions?
There is as Khaled said, there are a lot of questions from the audience, but many of them you already answered in your presentation. First one was, does healing of aorta after the balloon affect the surgical decision or not?
Healing of the aorta after the balloon?
If this can affect the surgical decision.
Actually, recoiled after the balloon. What happened is recoil or healing with fibrosis. So it regained again this narrowing and this coarctation. As we must know that balloon dilatation that we did is only palliative procedure in order to pass this critical situation. But the definitive treatment, of course, is surgery. It was not. It was just palliation. We didn't intend to have the full size of the aortic coarctation or a beautifully looking aortic arch and standing aorta. No, it was just palliation in order to have a better clinical condition for the surgeon in order to have his definitive repair.
Okay. I have a question about the LV function. As you showed in the echo, there was a very bad LV function before the balloon dilatation, and then there was a very good, there was an initial recovery of the function. My question is, does the function recuperate immediately, or it takes more time?
The views we showed inside the cath lab just after was on Wtrex.
Okay.
It recovered immediately, and even after the patient is not on Wtrex, after weaning this Wtrex, we saw that he had also a good ventricular systolic function. So we can say that the ventricular function was regained immediately.
Immediately, okay.
Yes, immediately.
Well, there is a very sophisticated question from the audience. It said there are some reports about using PGE in preterm babies developing aortic coarctation with duct closure, even avoid surgery in some cases for 2-3 months, putting them in a better shape for surgery. So basically, they say that in some case reports they have been using the PGE for 2-3 months. And this helped them, the babies, to be prepared for the surgery better.
Shall the child withstand staying in the NICU for this duration? Also, the PGE has its adverse effects. I think it will be difficult to maintain this care for a neonate. Also, this will he will be. He can catch infections. Many problems we have with this prolonged prostaglandin infusion. I think it's not easy at all.
Okay.
I believe it's a balance between how sick is the baby and how ready is he to do the operation. So I think it's a balance. Once he gets in a better shape, so that he is fit enough, then we should go for surgery or other intervention. On the other hand, as Yasmin said, long-term infusion has its problems, and one of the big problems here is prostate apnea. So they can get apnea and we have to mechanically ventilate them. So not the best in the world to maintain that chronically. But again, if the patient is very unfit or if in frank infection, maybe you want to pass that period.
Yeah, thank you. I believe so.
Yes, Mina, I think we have some questions about the dilemma of the pressure gradient across the coarctation segment and the presence and absence of diastolic tail.
Presence or absence of what?
Of diastolic tail.
Okay.
The presence and absence of diastolic tail, how does it signify the presence of coarctation, and the pressure gradient, as you just mentioned in this case, that the baby has an LV dysfunction, and this underestimates the pressure gradient. So it may be a misleading for the presentation. And I think, as you have just explained, that the most important point, and I would like to stress on, is the examination. Assessing the peripheral pulses in every neonatal child with coarctation is a key point.
Even with adults, even adults.
Even with adults.
Okay. In this figure here, we see you have a Doppler flow with from the suprasternal view with a diastolic tail. So you must have a clinically significant coarctation. Yet we have a pressure gradient which is around 30, 35, not that severe. That was because the patient had markedly impaired systolic function. This underestimates the pressure gradient across the coarctation, but didn't change the morphology of this, the pattern of the Doppler pattern. This Doppler pattern is diagnostic of aortic coarctation. The pressure gradient is depends on LV function, other loading conditions, blood pressure may change. But remember that this pattern is diagnostic of coarctation.
Diastolic tail is pathognomonic for coarctation.
Yes, you must furtherly investigate your patient for coarctation.
And if you don't have a diastolic tail, and you have a borderline pressure gradient, the examination might help by assessing the peripheral pulses. Am I right?
Yes, I forgot to say in my first case why we didn't had a diastolic tail. I think we didn't had it because the coarctation or the narrowing was diffuse and is present in the arch. I think that was the explanation for the absence of the diastolic tail, despite of having a significant aortic coarctation.
Probably also the presence of well-developed collaterals causes blood to run off through the collaterals rather than anteriorly through the aorta.
Okay, maybe another explanation. And post-stenotic dilatation. Okay. Other questions, or shall I shift to
I think
the?
we need to move.
Yes, move.
Yes. In illustrating, I wanted to get this spot diagnosis to you, as it is extremely rare, and maybe you may not encounter it in your usual practice. So I want you to see it in order not to be missed by some of us. This is a transthoracic echocardiography, a parasternal long axis view showing the mitral valve, showing good LV systolic function. Here we can see an apical view also showing the mitral valve. Is there any comment here? We can see an abnormal structure. You can see it moving here. The mitral valve itself is adequately opening. Leaflet maybe of normal thickness, but we have a structure here. If you put color, this is by color flow. I think this color aliasing should not be missed, and you should investigate what is the cause of this aliasing. And by pulse or continuous Doppler flow, this pattern is diagnostic of mitral stenosis. Shows you mitral stenosis, but we previously said that the mitral valve leaflets are adequately opening. So do anyone, I think we had someone previously asked that question, and I said that we will meet it in our slides. Did anyone answer what is the level of left-sided obstruction in this patient? Are there any answers from the audience?
So we have an answer of supramitral ring.
Yes, good. This is a supramitral ring. I'll show it again in order not to be missed from any of us. This is one of the levels of left-sided obstruction. We can see it isolated or in association with Shone complex. Actually, this patient had a previously repaired coarctation, and that was an association. So he had a Shone complex. So we answered it. And the difference between core triatriatum and the supramitral ring, I'll show it in the next slide. This is a diagram showing the supramitral ring, and this one is showing the core triatriatum. The supramitral ring is distal to the orifice of the left atrial appendage, while the core triatriatum is proximal to the opening of the left atrial appendage. Embryological wise, core triatriatum is related to the abnormal development of pulmonary veins entering the left atrium, while the supramitral ring is related to the embryology of the cardiac tracts, aortic valve and mitral valve development. So both are treated surgically by surgical resection. Of course, if patient is symptomatic and not controlled by medical treatment. So the supramitral ring is one of the levels of obstruction in the left side. If you encounter one of your patients with other level of obstruction, you must check the mitral valve, check flow across it. If you suspected any obstruction, take a Doppler flow, assess the pressure gradient across the mitral valve. Okay. Shall I shift to the other case?
Yes, please.
Okay. This case also is an adolescent. He had dyspnea on moderate exertion. He had attacks of pre-syncope, yet with no chest pain. His apex in the left fifth intercostal space at the mid-clavicular line. He had sustained forceful apex, systolic thrill in the upper right sternal border with ejection systolic murmur in first aortic area radiating to the apex, suprasternal notch and neck. Once you encounter this murmur, I think you must think of aortic stenosis. And you must furtherly investigate the level of this aortic stenosis. So we have an adolescent who is symptomatic with attacks of pre-syncope and normal cardiac dimensions, yet he had aortic stenosis.
So we are expecting having either a subvalvular, valvular, or supravalvular aortic stenosis.
The site of this murmur showed is mostly valvular. It's not subvalvular, but should be furtherly investigated to be sure of your level of obstruction. This was his ECG. It shows LVH with strain pattern, and this his chest X-ray. It showed a dilated ascending aorta, normal cardiac dimensions or cardiac size, a prominent aortic knob. It goes with aortic stenosis, valvular aortic stenosis with post-stenotic dilatation. Actually, I don't have the full echocardiographic examination of that patient, yet I had his right parasternal view, as it is very important to assess the pressure gradient through this view. You can get it by having the patient leaning on his right side, the right lateral position, opposite to what we used to do, with the knob of your transducer facing upward, sometimes in the right parasternal area. Sometimes it's a little bit difficult to get that view, yet I myself use the color turbulence in order to lead me to be properly aligned and have this Doppler flow in order to precisely the gradient across the aortic valve, because the usual apical 5-chamber view may underestimate the gradient. Even in some adults, I encountered some patients whose suprasternal view showed a more or better aligned flow of the aorta and get a higher pressure gradient than apical. So you must examine your aortic flow from different views, and you will rely on the highest gradient that you will record. The flow in case of right parasternal view is towards the transducer, so you will find it upward, opposite to what we record in the apical 5-chamber view. Here we can see the patient more than 4 meters per second in velocity, showing a severe aortic stenosis. And you can see a thickened valve here, thickened aortic valve. There is no supravalvular aortic stenosis. And that was his full echocardiographic report. He had normal dimensions, he had concentric LVH with no aortic regurgitation. He had the aortic valve was tricuspid and thickened with an aortic valve annulus 18 millimeter. In some cases, if there is difficulty assessing the aortic annulus by transthoracic echo, you may use the TEE. It gives more accurate measurements of the aortic annulus. It's important for cath lab in order to choose your balloon, and also for the surgeon in order to decide his surgical technique, or the prosthetic valve will be needed. There was no associated subvalvular or supravalvular stenosis. The maximum pressure gradient was 70 with a mean gradient of 40. And again, you should revise all your views and not depend on one view to record your maximum pressure gradient. And here I wanted only to show you that there are different ways to assess the peak pressure gradient. And that measurement of the pressure gradient by echocardiography, which is called the instantaneous pressure gradient using the Bernoulli equation, depends on the velocity across the valve, and it is 10 to 20% overestimating the pressure gradient that taken with sedation inside the cath lab, which is called a peak-to-peak pressure gradient. And the instantaneous mean pressure gradient usually shows us the pressure gradient in relation to time. So these three different, you must be aware of these three different measurements of pressure gradient in order to be able to precisely classify your patient, to have a mild, moderate, or severe. By echocardiography, less than 40 is considered mild, 40 to 70 moderate, more than 70 is severe. Yet inside the cath lab, it's completely different with under sedation, under anesthesia, and the peak-to-peak gradient is much less, or 10 to 20% less. Less than 30 is mild, 30 to 50 moderate, and more than 50 is severe. I think enough for this slide, and then we will do some brainstorming. How would we manage each patient?
Sorry, before going to the management, thank you so much for stressing on the issue of assessing the valve in multiple views, especially the apical 5-chamber, the right parasternal, and the suprasternal, as we can get a pressure gradient that's higher from the suprasternal rather than the apical 5-chamber. We have a question about the morphology of the aortic valve, whether it is bi-leaflet or tri-leaflet. Any tips and tricks for assessing?
I think you can get a little bit higher with your transducer in order to assess the aortic valve morphology. Sometimes it's difficult in an adult to see the exact morphology of the aortic valve, especially that some patients with bicuspid aortic valve has fused raphe. So you cannot say this is tricuspid or bicuspid valve, and you may need to do a TEE, which gives a much better view of the aortic valve and its cusps. Can help you to determine whether it's bicuspid or tricuspid. A second point is the eccentric opening of the valve can give you a clue, is it bicuspid valve or tricuspid? If you have eccentric openings, it's mostly bicuspid. And that's all, I think.
Okay, so we are facing an adolescent who has an aortic stenosis, and by the pressure gradient from the right parasternal, it is a severe aortic stenosis.
Yes, he's symptomatic.
He is symptomatic.
Mm.
So we need to manage. And I think that it's a borderline case, and would lead us
He's
to
an adolescent.
He's an adolescent.
Yes, 13 years old with an annulus 18. I know this.
He's an annulus 18.
For surgeon, for of course, will not allow prosthetic valve placement. And Dr. Hatem will say to us what can we do.
Having a surgeon on board would help, but I think all options are available.
Mm-hmm.
So honestly, in these cases, we prefer surgery. Mm-hmm. So there are different surgical options, and none of them are perfect. So one option would be, since the patient doesn't have a lot of aortic regurg, almost no aortic regurg, so one option in such an adolescent will be doing a limited commissurotomy without doing too much damage to the valve, so that we can maintain as much valve function as possible. While doing that openly under direct vision, so that we open into the commissures, and then this can decrease the gradient. However, it does not get that to normal pressures, obviously. But then the aim of this is to get as much improvement of valve function as possible till he grows older, and then the options would be easier. On the other hand, the best option here.
May I have a question before going to the other options about the incidence of recurrence and aortic regurgitation in open commissurotomy?
So as you say, we never come out of theater with no gradient. It's almost always there is some gradient, but it's usually much less than when the patient with the patient presented with. So, and this can improve ventricular function and give him time, but we know that this is a relatively palliative procedure. On the other hand, yes, patients can get significant aortic regurg, and it depends how aggressive were you when you open the commissures. And on the other hand, it depends a lot on the valve morphology. So is it bicuspid or tricuspid? Is the bicuspid was symmetrical cusps or not? Any calcification or a lot of thickening. So it depends a lot on the valve morphology. But yes, you tend to get like mild to moderate regurg on that.
Okay, so it's double-edged weapon.
Yeah.
You might have a lesser pressure gradient on the expense of having more aortic regurgitation and vice versa.
Yeah. Yeah. On the other hand, we believe the best option for such a patient would be to have a Ross procedure. And for those who are not familiar with the procedure, so it's taking out the aortic root, which is the diseased root, so excising that. And on the other hand, harvesting the pulmonary root, the normal pulmonary root of this patient, and then putting that into the aortic root, and then putting ideally homograft into the RV to the pulmonary. So the benefit of that is that the normal pulmonary root of that patient has the best performance ever of any valves that we have tested. And maybe you think, why don't you just put the homograft into the aortic root? Because the homograft tends to degenerate a lot faster if it is put on the high pressure circulation. While if you put the homograft into the low pressure circulation of the pulmonary, you usually tend to get good long-term results. So the Ross procedure is a technically very demanding procedure, and it requires the presence of homograft. But recently, many valves have been used for the pulmonary position. So people can put bioprosthetic valves or other alternatives on the right side. So not necessarily homografts, although the best long-term results are with the homograft. So let's talk about the long-term results of the Ross procedure. A big study has been performed in the UK on patients with Ross procedures. And it was found that those who had the Ross procedure had comparable survival after 35 years to normal population. And this is unheard of. So no other surgery to the aortic valve can ever achieve that. So although these patients obviously had reoperations because of the having to change the conduit of the homografts, although some patients stayed for 20 and even 30 years before having to replace that, but obviously others had to replace that earlier. Also now with the age of the percutaneous valve, the homograft can be replaced by a percutaneous valve, not necessarily an open surgery. So as far as we know, for surgery of the aortic valve, the Ross procedure has the best result. Although it is a really technically demanding procedure, it's a very big operation. Obviously, needs a lot of experience and training, but the long-term results are the best, and it provides the benefit is that this is the only valve that can grow with the patient because it is a living valve. So if you put a pulmonary valve into the aortic position, this valve will actually grow. So this is the option of the Ross procedure. There are other options now for aortic valve. One technique has been getting more popular is the total replacement of the three cusps with autologous pericardial cusps of the patients, and that is refashioned for replacement of the three cusps. It is described as the Ozaki procedure, and this is also getting a lot of popularity, especially with the children, because it's a stentless. There's no gradient there. It has shown very good results, but we don't have yet very long-term results, at least in children with that patients. But it is obviously promising. And the last option here would be aortic root enlargement with a replacement of an either mechanical or bioprosthetic valve. So doing something like the Kono procedure, and then this enlarges the aortic root, and then you can put an adult size valve with it, which is also not an easy or a small operation.
Would you please illustrate the difference between the Ross and the Kono Ross, as we have a question about the Kono Ross? What is the Kono procedure?
So the Kono procedure is that the classic Kono, is that you excise the aortic valve, and then you cut through across the aortic annulus into the muscular septum. So roughly in the middle of the right coronary sinus, you go downwards into the muscular septum there, and so you open the left ventricle into the right ventricle across the septum. And so the whole aorta, the LVOT will open, and then you can put a patch there so that you enlarge the LVOT, and then you continue with the Ross so that you take out the pulmonary pulmonary autograft, put it on the aortic position, and put a homograft on the right ventricle. One modification of that is that because with the Kono procedure, you essentially cut across the aortic valve, so you have to replace the aortic valve. In patients with tunnel LVH obstruction, but adequate aortic valve, ideally you do not want to sacrifice a normal aortic valve since it's a big issue for a child. So a modification of the Kono is that you can cut across the muscular septum without going through the aortic valve, and then you still put a patch there. So this is a modification of the Kono. Obviously, you do not enlarge the aortic root as much, but then you expect that the aortic root is not too bad because the gradient was just a valve. So this is the Kono procedure. So Kono procedure is enlarging the aortic root by cutting across the muscular septum. Sometimes it is done with the mechanical valve or can be done with the Ross. But most of the time, if the patient doesn't have tunnel LVOT obstruction, even if the aortic root is small, only doing a ROS usually is sufficient.
So in cono, you are creating an iatrogenic VSD to enlarge the LVOT, and then you close it with a patch.
Yes. So there are different ways to enlarge the aortic root. So you may cut into the middle of the non-coronary sinus, and then you cut across the annulus there. This is the next. Or you cut through the commissure between the non and the left coronary. And then you put a patch there. You can go into the anterior mitral leaflet, and the patch can extend into the anterior mitral leaflet. This is the menugion. Or you can cut on the opposite side into the muscular septum, roughly in the middle of the right coronary sinus. And then you go across the annulus there into the muscular septum. This is the cono. Usually you get the best, the largest enlargement by doing the cono, and it is actually the most difficult operation of the three.
Okay. And before leaving us, so we can conclude from the surgical techniques you have just described that the most preferred are either an open valvotomy with an incidence of both stenosis, residual stenosis and regurgitation, or a ROS procedure with an incidence of calcification in the conduit and the need for reoperation within 15 to 20 years.
Honestly, I believe if the experience and the valve, the homografts, I mean, are available, the ROS procedure would be the best option. Otherwise, the second best option here would be either a commissurotomy or an Ozaki procedure.
And is there a rule for a palliative procedure as a bridge to surgery to gain more time?
Yes, obviously people have done balloon, and many have got very good results. I leave Yasmin to talk about the balloon, although the risk of acute severe aortic regurg here is significant. But,
being an interventional, I would also like to hear about balloon.
In my opinion, in case we have no available ROS procedure, I would give a patient a trial with the balloon, taking the risk of having aortic regurgitation. But let's pray not to be acute aortic regurgitation, acute severe aortic regurgitation. I will take the risk. I will take that risk and give him a trial of balloon dilatation till his annulus enlarges a bit, and this will allow you to do all your possible surgical techniques later.
This is obviously a really challenging condition, and
yes.
that's why when we were talking earlier about patients with subaortic membrane, and now the subaortic membrane is approaching the aortic valve, this is a really serious condition. We should try as much as possible to preserve the aortic valve because the options are not ideal. So and other conditions like patients with VSD and cusp prolapse, and then we're risking that the aortic valve gets destroyed. So we should really try very hard to preserve the aortic valve of the patient because there are no ideal options here.
Yes. It's a very risky procedure and carries a high risk of aortic regurgitation. Yet, in absence, if ROS is not available, I think we may have this risk. I will revise: the patient is symptomatic with good LV function. He is an adolescent with annulus size 18. He had no aortic regurgitation, which will encourage me to take that risk, and patient preference. Not always we may rely on this. To summarize, indications of intervention in valvular aortic stenosis: if you have an isolated valvular aortic stenosis with a peak pressure gradient more than 50, or if you have an LV dysfunction or critical valvular aortic stenosis in a neonate or a pregnant lady, or a lady who wishes to be pregnant, or an athlete with pressure gradient more than 50 and positive exercise test, or even a pressure gradient more than 40 with presence of angina and syncopal attacks. All these are indication for intervention in valvular aortic stenosis. Then this already we discussed all these possible of course, this patient is not for medical treatment. He is symptomatic. He should be intervened upon according to the slide I previously showed. So the debate now is whether to treat him surgically. Of course, ROS is a very good option and we should go for it. But in case we have no available ROS procedure according to Indian guidelines, in an asymptomatic or symptomatic patient with aortic stenosis, severe aortic stenosis, pressure gradient more than 64 and the mean more than 40, patient should be taken to, or maybe justified to be taken to cardiac catheterization to have an elective balloon dilatation. So this was the patient inside the cath lab. Here you can see the tricuspid thickened aortic valve, and this is the balloon dilatation. And there is here what happened. We have at least moderate regurgitation, who will be the patient will be kept for medical treatment for some time until he will be operated upon. That was the whole case. And lastly,
yes, before moving to this slide, we have a question about the technical issue. What about the balloon sizing in patients with congenital aortic stenosis? How do you choose the size of your balloon?
Unlike balloon pulmonary, for example, that we take a balloon size 1.3 or 1.4 or even till 1.5 times the annulus diameter, in balloon aortic valvuloplasty, we should take a balloon only 0.9. We should take it less than the annulus size, 0.9 of the annulus size, in order to avoid aortic regurgitation, as more the larger balloons are associated with higher degrees of resulting aortic regurgitation. Okay.
Okay, thank you.
Shall I move to the
yes, please.
next slide? This is lastly, I will talk about supravalvular aortic stenosis. It have the same clinical symptoms and signs like previous levels of aortic stenosis, yet one of the most specific signs of the supravalvular aortic stenosis is Coanda effect. What is Coanda effect? Is that there is a higher systolic blood pressure in the right arm more than the left arm. This is because the antegrade flow from the left ventricle to the aorta is directed by this supravalvular stenosis into the innominate artery, so that we will have a higher systolic blood pressure in the right arm than that encountered in the left arm. Supravalvular aortic stenosis may be isolated, or it may be a part of Williams syndrome. Williams syndrome is characterized by mental retardation and these facial characteristics. Once you meet a patient with supravalvular aortic stenosis, I think you should do a multi-slice CT to assess well the geographic degree of this stenosis, to assess also your pulmonary arteries, as it may be associated with supravalvular pulmonary or more peripheral pulmonary stenosis. You should also examine your RV pressure by transthoracic echo. Indications for intervention, it has a higher threshold for intervention with pressure gradient more than 64 millimeter mercury with symptoms, or new aortic regurgitation, or LV dysfunction, or severe LVH. Also, don't forget that supravalvular aortic stenosis may be associated with coronary ostial stenosis, which may cause ischemia. You should investigate well if patient has symptoms suggestive of ischemia, and by multi-slice CT, coronary osteo must be assessed well. I think that is all.
Thank you so much, Yasmin, for an elegant talk, which raised a lot of questions. I know you are a bit exhausted, but we have a large pool of questions from the audience. I'll start with the first one from Dr. Ahmed Fouad. Is there a relation or association between core tritratum and supramitral ring?
No, they are not associated. They are just different levels of obstruction above the mitral valve, supramitral obstruction. They are types of supramitral obstruction. Yet the core tritratum is not, for example, we don't see it as a part of Shone complex. It's abnormal development of pulmonary veins insertion into the left atrium. It's not part of our lecture today. It's not a left-sided obstruction. It's abnormal development of the pulmonary veins into the left atrium. Yet it may cause a significant obstruction at the supramitral level.
Okay. A question from Dr. Paula Shahdi. Why the indications to intervene in congenital aortic stenosis varies from those of rheumatic aortic stenosis?
I think that maybe because the patient in younger age will not be that symptomatic. Symptoms will not be encountered that early, and that aortic stenosis is associated with the risk of sudden cardiac death. So the long term of congenital aortic stenosis since early ages for prolonged time may cause sudden cardiac death even without that relevant symptoms.
Yeah, and I would add more that I think the main difference would be the morphology of the aortic valve leaflets. The morphology of the valve leaflets in rheumatic aortic stenosis is much worse than in congenital aortic stenosis, and I think that's why balloon wouldn't be more preferred in patients with rheumatic aortic stenosis.
Okay.
Do you agree with me?
Yes, of course, sure.
Okay, and another question from Dr. Hagar Mustafa. Can familial hypercholesterolemia present with supravalvular aortic stenosis at a younger age?
I think it may present with valvular aortic stenosis.
We see more with valvular aortic stenosis.
More with
coronary
aortic stenosis. In addition, actually, to coronary lesions can very well be associated with atherosclerotic coronary disease, actually requiring coronary interventions like CABG in 17, 20 years of age.
I agree with you. I think the association between familial hypercholesterolemia and supravalvular aortic stenosis is quite rare.
Mm.
I think we are done for this night. Thank you so much, Yasmin.
Thank you very much, Yasmin. Very nice talk.
And thanks, Hatem and Sarah, for an elegant moderation.
Thank you very much.
And I would like to pass the mic to Zahran.
Thank you so much. I enjoyed this session. Really, Yasmin, you did a great job and a very big effort to express all those lovely cases with all the different options for intervention, for surgery, the medical treatment, where does it land for, where can we use an intervention as a bridge to surgery. Thank you so much, Yasmin. You did a very big effort today. Thanks so much, Sarah. I know you were overwhelmed today by flight and everything, but thank you for joining us, contributing and doing the big effort today for this long webinar. Thank you, Khalid Shams, because you were responsible for organizing and managing this webinar from the start. So thank you so much for your big efforts. Hatem, you are always the best player in the team because no one can beat you in surgery, and you are the only surgeon on board, so you always teach us a lot. and we are all learning from you, and we are all learning and gaining more experience from your valuable contributions and
Thank
comments
you very
with
much.
us. Thanks to the whole congenital heart disease team at CEC, and thanks to the CEC board. Next Tuesday, we will have a great session in the bifurcation campus about straightforward provisional stenting and compared to the two-stent technique. And next Thursday, we will have a very interesting hypertension cases for secondary hypertension with Professor Hatem Sukari to complete the topic that was discussed 2 weeks ago. Thank you so much, all our audience, and we hope to see you soon, inshallah. Bye-bye.